This patient was 72-year-old gentleman. He was admitted into our hospital, presenting with exertional chest discomfort for more than 7 years, aggravated for 2 months. This patient 7 years ago received 2 drug-eluting stents were deployed in right coronary artery. And his risk factors include essential hypertension and diabetes. Lab tests at our hospital showed his eGFR and BNP were almost normal. ECG found T-valves inversion in leads V2 to V6. This was the baseline ECG. From angio, we could find severe stenosis in middle right coronary artery. Today, the target lesion is the left coronary artery. From the baseline angio at 1 month ago, we could find from the from the epicardial view and the spider view, we could find the distal left main bifurcation, Medina 111, and with severe calcification. And the length of left circumflex is very short. From AP cranial view and right IO cranial view, first diagonal and the second diagonal looks normal. The syntax score for the patient is 39. We also calculate the syntax 2 score. 4-year mortality for PCI was 6.3%. 4-year mortality for CABG was 8.9%. According to definition criteria proposed by Professor Sao Liangchen, this distal left main bifurcation belongs to simple bifurcation because of the very short length of left circumflex. Today, the target lesion is left circumflex, and we plan to perform IVUS guided PCI with IBP standby. For severe calcification in distal left main and LAD, we maybe use rotational atherectomy or intravascular lithotripsy if needed. For distal, simple distal left main bifurcation, we plan to use provisional stenting.
Very severe calcification from the distal left main to the distal LD. Some the tortuously the vessel, severe disease located the distal left main, and also severe disease at the middle LD. We prepare the rotation on the IVUS. And probably we use the intravascular image to evaluate this disease and to make sure if we use the router or the IVUS or nothing used. Okay. For this case, we use the radial axis is 7 French. And also because this the disease located the distal nerve main, and so we prepare the right femoral artery to use the 6 French to sheath and prepare the preparation for there. Probably we use the IBP or another mechanical support for this case. First of all, we used this CM balloons wire advanced to distal LD. And want to check the IVUS first.
Distal vessel is normal, and the vessel diameter about 2.8 millimeter. Then go on pull back, we can see an eccentric plaque. Then go on pull back, we can see calcified plaque. Go on in distal LAD, we can see the calcified loader. Then go on pull back, here we can see the LAD and the diagonal bifurcation. Here, this is second diagonal, and we can see the second diagonal vessel is normal. Then go on pull back, this is the middle LAD. In middle LAD, this point, we can find this point is the minimal lumen area. The area is just 1.4 millimeter square, and the plaque burden is more than 87%. And here, the in middle LAD vessel diameter about 3.7 millimeter. Then go and pull back. Here we can find another side branch, and here this is the LAD and the first diagonal bifurcation. And here we can see the osteomer diagonal is normal too. Then go and pull back. This is a proximal LAD, and the proximal LAD vessel diameter about 4.0 millimeter. And then here the proximal LAD, the plaque is a calcified plaque, and the calcification angle is about 270 degrees. Then go and pull back. This is the proximal LAD. Go on here, we can find the another bifurcation, and here this is the LAD and the circumflex bifurcation, and this is the ostium LAD. Then go and pull back. This is the POC, and this is the distal left main. In distal left main, we can see the calcified loader. Then go and pull back. This is the middle left main. The body left main vessel diameter about 4.8 millimeter. We measure from the distal landing root to the second diagonal, the netness is about 26 millimeter. And from the distal reference to first diagonal, the netness is about 46 millimeter. Then from the distal reference to the first diagonal or to ostium LAD, the netness is about 86 millimeter. Okay, this is a baseline IVUS imaging.
Okay.
So I completely agree with what you mentioned, that imaging guided approach, possibly using rotational ablation and also using IVL would be the best way to get the vessel prepared for stenting. Diffuse calcification, severe involvement of the bifurcation site. I like your plan of having intra-aortic balloon pump standby.
Say this patient is distal nerve and because the eject fraction is normal, and I don't want to put the mechanical support, unfortunately, so I already punched the femoral artery. Okay, because the distal nerve bifurcation, based on the definition, the criteria, and there is a simple bifurcation. Also, circumflex is not a big vessel, so I want to use the provisional standing for the distal nerve. Okay, is I want to use the body wire to do across to the this lesion. Okay, because we use the IVUS catheter is not easy across the lesion. Based on IVUS, the measurement calcification is not severe, so I want to use the non-compliant balloon to prepare this lesion. Probably use the goring or not the cutting balloon to prepare. Use the body wire and use the 2.25 non-compliant balloon to prepare the distal LD.
What size balloon in this?
2.25.
High pressure.
14 up. 8. I want to use another larger non-compliant to prepare this middle LD. Here is some of the resistance. So 2.5. Here is 2.5 non-compliant balloon.
14.
The balloon expanded very well here. Yeah. Okay. Okay. For the distal nerve man, because the large vessel, I want to use the 3.0, the non-compliant.
But you did not dilate that segment with the 2.5. You want to go directly with the larger.
Yeah. Here I want to the test to. Okay.
Looking good. Looking good.
Okay. This is 3.0. Oh yeah, good.
Expanded very nicely and easily.
Yeah. Yeah. Good.
And expanded very well there too.
Yeah. Give some the nitro. I want to check IVUS again. IVUS per ready. Go.
This
Yeah.
left main and the LED looks all right.
Probably some of the cornea shift to the second diagonal. Probably use another wire to protect this diagonal before the standing.
Right.
Okay. Come. Okay.
Okay.
So it's very curved. Seems like not easy to cross. This cannot cross.
Yeah.
Yeah. So it's the middle LD is very torturous. So I don't want to. Use another 2.5 component balloon.
That was a little surprising there, considering how well the previous balloon had expanded there.
Yeah. So
this is the
same. The middle
2.5,
LED. That's
just before the second diagonal, between the first and the second diagonals.
Yes. Okay. Here. Seems like the balloon expanding. It's good.
Yeah, very well expanded.
It's just, I think it's just because it's a tortuous vessel. So here.
Sure.
Yeah. Here.
Should be much easier now.
12, 14. Yeah, 16.
16.
Here, okay. Here. Yes. Probably okay, it's good. Okay, here.
8.
Okay.
10.
You see? It's very
well expanded.
Yeah. Okay, I want to try again. IVUS caster
And this is a 7 French system you're using?
Yeah, it's the same French. Yes. Okay. The flash.
Which IVUS system is this?
This Boston Scientific.
Excellent.
Yeah. Yeah. I want to. It's easier than
Okay.
before.
Goes there
Yeah.
much, well, a little bit.
To try to engage and then to problem
All
is
the tortuosity.
yeah. But the thing is cast is soft. It's not cross. Probably removed.
Not tracking, and
Yeah.
I think you need to make a decision independent of that.
Yeah, I want to check. Yeah.
Let's maybe have another angiogram and then try to make a.
Yeah,
it's very nicely.
It's very nice.
the
I think
non-
probably
non-
we can try the standing. Before that, I move this Y into the diagonal. Okay. Yeah, also it's not easy. I think here you have.
All right.
Okay,
Very good job with the.
here.
Probably need to go into the.
Here.
you-
Okay.
Yeah, you're in the right place.
Let's stand. Still here.
So as you put in, you're planning to put in a.
Yeah,
a
stand. 2.5 stand.
Okay.
Based on the IVUS is
that was a rough size approximately. Okay.
yeah, stand cross smoothly.
Yes, easily.
So
it was surprising why the IVUS catheter is not.
Based on the IVUS probably is here is the
Maybe a
plaque
little-
burden is
right.
less than 15%. So I want to
avoid that.
it's a good position.
Yeah,
Yeah.
looks good enough.
Yeah.
Maybe,
So
maybe.
okay.
8,
9.
9,
Good. 10.
10.
Yeah, great. Okay. Another stand. 2.75.
33.
Yeah, and I want to do a picture.
Yeah, let's see how it looks. Looks
Good.
very good.
What is it? For here is a dissection. Move the photo view. I want to see what is it. Good.
Okay.
Okay.
Well, the circumflex is looking just fine.
Yeah, I think so.
The one in the AV groove, of course, there is a tight lesion there at that angulation, but at least the ostium is just fine.
Yeah, ostium is fine. Its surface is small, and the OM probably is a bigger one than one.
Right.
Yeah, here, no.
Sure. Yes, I will ask them. Yes. So far, we approached complex bifurcating left main, moderate calcification, considerable angulation and tortuosity, which one of the initial intent was that we would be using a rotablator, even considering IVL. But so far, it has been relatively straightforward, probably because the calcification was really not that dense and 3 or 4 quadrants. So with the high pressure balloon, we made much progress. And of course, now we'll be approaching the left main and we'll be addressing that. In the meantime, I'm sure you're seeing the further expansion of the proximal LAD, the ostium, and the distal left main, and where we continue to make progress with the wiring of the left circumflex. That's a long left main stent. I like the position of it. And again, let's see how the vessel responds to it. Once again, a very good clinical decision. I think that just a high pressure balloon was used.
Okay.
That looks very good there. You're making excellent progress. I thought a slight, maybe a dissection or something at in the slightly
3.5
distal to
后
the
面就是
first
4.5
diagonal.
的
Or,
pot.
yeah, exactly. That would be the right way to do it. Do you have any further plans which you want to discuss?
Yeah, I already put the 3 stand from the distal LD to the left main.
And all of them look good and well
Yeah,
expanded.
it's this picture. Is that show the picture? Is
You're planning to do part now?
yeah. Here I want to do the post dilation.
Yeah.
From the distal and to the
The LAD
LED.
and the left main in the meantime look excellent. Both the first and the second diagonal look very nice.
Yeah, yeah.
So excellent decisions. I'll let you continue. Tell me, bring me up to state with what all you have done. I
Sure.
know the vessel has been looking very good.
Yes, yes. This is 3.5 long compared to post-dilate to the proximal LG. And here, post-dilate,
Sure.
the 16.
16.
And is your plan just to protect the circumflex, or are you planning to do something to the OMB? It's actually the OMB was fine.
Yeah.
It is just the circ in the AV groove, but probably leave it alone, no?
Because the ostium is the circumflex is okay. I think probably it's just use the wide protected
Absolutely,
enough.
exactly
So
what I
yeah,
thought. Yes,
yeah.
excellent.
Okay.
I like your strategy. So far, our initial approach of stenting
16.
across
16, yeah.
and
18.
has been working fine. A lot of high pressure balloon along the diffusely diseased vessel, and of course, we'll be doing a run with the IVUS to demonstrate to
18.
you how I'm sure the vessel will become much more compliant.
Sure.
What methods do you use to assess the adequacy of stent deployment? All image guided. So what has
Yes.
been your further progress in this case? Anything you have changed from your initial plans?
If the circumflex ostium is compromised,
Right.
yeah, probably we use the casing balloon information. But from this angiogram, and I think the ostium is good.
Looks
And
very good.
yeah, it's a portal balloon is designed by the doctor Shang Chen.
Yes.
And to show there is what is the portal?
So the one designed by him, which company is manufacturing it?
The master Chinese company.
Excellent.
Yes, it's a very short a very short shot.
About 6 millimeter.
Yeah, 6 millimeter.
Yes.
Yes.
Excellent. So
To the port for the bifurcation
so
is
doctor
great.
looks all right.
Yeah. So
although-
I want to check IVUS finally.
Okay, so that was the question which somebody has asked. We'll give you the answer
Okay, thank you.
with IVUS. So what is the average? How much is the volume of PCI in China at the moment? Is it already the world's biggest or catching up soon? I think.
You mean my center?
No,
Or the Chinese
for the country.
Well, country 1 million. Yeah.
That's what I thought. Yeah,
Yeah,
with
more than 1 million. Yeah.
more than a million. So
Yes.
I'm sure that the world's biggest PCI use is going to be in China and India, and just the epidemic of coronary artery disease. I'm sure that even in China, you're seeing more and more diffuse disease in younger and younger patients.
Yes. Some
All right.
patient,
So the IVUS catheter, which previously could not even cross, is now into the mid to distal segment, and we'll get an excellent imaging.
I want
sure
to
we'll
check
find a good stent expansion.
Yeah, I
here.
just check IVUS from here. Okay.
Okay, let's
Open
do
it.
Yeah.
Yeah.
From here, I will pull back.
Yeah.
Yeah, this is distal LED. In stand diameter about 2.75.
Very good so far.
Yeah.
I'm sure you're happy with the result, and the expansion is good.
Yeah.
Side
Is the
branch,
diagonal?
maybe
Second diagonal?
the second diagonal. Yeah,
Yeah.
this is in middle LED. The stand diameter is more than 3.0.
Okay. So which
Okay.
is where you were tapering down and taking it to 3.5.
Yeah. The normal diameter almost 3
Yeah.
millimeter.
That place, you wonder if there's a little more further post balloon dilatation, but looks all right. I think.
Yes, yeah, I think.
This is the first diagonal.
Yeah, this is the first time.
So here is a proximal LED.
And how much is the volume of structural heart at your institution? I'm sure it's to get a national number is very tricky because those numbers keep changing, but you're doing more and more, I'm sure, structural every month.
Structure, yeah, we do every month structure, but structure is how intervention is in China is probably is delayed for the European or USA.
Sure.
So probably is
Cost.
the several source
Yes.
source the cases will be done in China.
Excellent.
Recommend?
Yeah, nevertheless, the proximal stand age is normal, no dissection. Okay, I will
Okay.
stop.
Because the osteum the new man is so okay.
Yeah.
Stand is not covered. Yeah, I'm very happy with this final result.